Thank you, Dr. Biko, for giving up your time today to answer some questions in recognition of World Fertility Day. The questions were posted to IFAS's Facebook page by our followers, and I know your input will mean a lot to them. Please, can you start off by telling us a little bit about yourself and about Femicare Fertility Clinic, where you are situated, etc.?
Thank you, Saskia, for inviting me to this meeting, online meeting. And I want to thank IFAS for taking the baton for the patients to assist the patients in this very, very difficult journey of infertility. I'm Dr. Jack Biko. I'm a registered fertility specialist. I've been a specialist for more than 10 years. I had my training mostly in Pretoria, some of it overseas in Spain, in the UK, and in Germany. Now I'm the director of Femicare Fertility Clinic. It is a fertility and an advanced endoscopic surgery clinic, which means that we do fertility work, all aspects of fertility, from timed intercourse to IVF, ICSI, to biopsying of embryos, and we do advanced endoscopic surgery, especially endometriosis surgery, such as stage 3 and stage 4 endometriosis surgery, to enhance patients' fertility or to manage their pain symptoms. Femicare is based at Netcare Feminine Hospital here in Pretoria, Arcadia, Pretoria.
Excellent, thank you. And today your topic is anything fertility related. So the patients could ask you anything they wanted to. I thought that was quite brave of you to take on that topic. But I think the questions are quite nice.
Okay, let's hear.
All right, let's get started. So how long can eggs, embryos, and ovarian tissues be frozen for?
All right, so eggs and embryos and ovarian tissues can be frozen for a long time, quite a long time, but we can't say exactly for how long, because they've been done for the past 15 to 20 years only. And ever since then they were done, we've been able to freeze them for as long as they were being done. So maybe 30 years, maybe 40 years, maybe forever, we don't know, but it has been thus for more than 15 years that we've been freezing eggs and embryos. Now, ovarian tissue freezing is a new concept. It's been done over the past 5 or so years. So again, we don't know how long we can keep it frozen, but possibly for as long as it's possible. But for the time being, the information that we have, it's about 5 to 10 years that's available that we can talk about it.
Okay, thank you. Okay, if I'm in menopause, can I carry a baby?
All right, so there's a difference between falling pregnant and carrying a baby. Now, any patient who has a womb, irrespective of their age, will be able to carry a baby if the womb is normal. So any patient in the menopausal age range who has a womb will be able to carry the pregnancy, because we can support the pregnancy by giving external hormones to maintain the pregnancy. So yes, during your menopause, you can carry a pregnancy if you have to fall pregnant. However, we have to use donor eggs and fertilize them with your partner's sperms, and then transplant that embryo, transfer the embryo into the menopausal womb, which has been prepared hormonally, and then normally they can carry the baby to term. So it is possible.
Thank you. Okay, what is preimplantation genetic diagnosis, or PGD?
All right, now we know of some cases whereby patients, they deliver abnormal babies or babies which are genetically affected by certain conditions. And the effect of that, it is very stressful for the patients to deliver these babies, to carry a pregnancy for 9 months and not knowing if your baby is fine or not fine. So PGT or PGD is a test that we do on the embryos before we transplant them into the uterus to exclude a particular disease that is affecting a particular family. So we don't like to just do it randomly for everything, but it has to be done for a specific condition to exclude the presence of that condition, so that in that particular embryo which is affected, we don't transfer that embryo into the womb of the mother of that patient.
Thank you, doctor. Okay, what is secondary infertility?
There are 2 types of infertility in general. There's primary infertility and then there's secondary infertility. Now, primary infertility refers to those patients who have never been pregnant and never carried the baby to term, or something like that. Now, in our continent, the biggest problem is secondary infertility. This is where patients fell pregnant before and often had a kid before when they were younger, and now they're struggling to fall pregnant. So secondary means that you were pregnant before, and now you're struggling to fall pregnant. And the commonest reasons for secondary infertility would include things like infections, pelvic infections, endometriosis, surgery for whatever reason can impact the functioning of the tubes or the ovaries. So secondary infertility is a patient who was pregnant before and now they struggle to fall pregnant. And as I said earlier on, it is the commonest cause of infertility that we see in this part of the world.
That's very interesting. Sure. Okay, number 5. If we have been trying for a while and haven't fallen pregnant, what can I expect from my first visit to a specialist?
Wow, it's a good question. Well, you can expect to meet a very friendly specialist who's going to listen to you and take your word for it, take your opinion for it, and then they will talk to you and explain to you the process of falling pregnant, because many patients assume that once they get married today, tomorrow they will fall pregnant. So it doesn't work like that. So your friendly specialist will explain to you the process of falling pregnant. They will explain to you that it takes time. When everything is normal, it takes time to conceive. In young patients, it takes up to a year to conceive. So we'll explain all of this stuff for you. And then secondly, they will do some basic investigations, right? Often before we do the test, we can tell the couple, advise the couple about ovulation, when is the window of implantation and stuff like that, so that we can advise you when is the best time to have intercourse for falling pregnant. There's intercourse for pleasure, there's something else. But for falling pregnant, we can advise initially as to when is the best time to conceive. If that doesn't work, then we're going to do investigations. And the first 2 common investigations that we will do would be to assess if the tubes are open, if there's any pathology in the womb, like fibroids and stuff like that. And then at the same time, we'll assess your male partner to see the parameters of the sperms, because in South Africa, the commonest reasons for patients not falling pregnant include sperm problems, blocked tubes, and patients not ovulating. So those 3 things are probably the first things that we're going to check to ensure that the common things are sorted out first before we go to do the other invasive tests. So it's a sperm test, tube test, and to check if you're ovulating, and then we're going to educate you as to when is the best time to conceive and how to have a better chance of falling pregnant, just by getting more information and being knowledgeable about your body and about your hormones and your partner's hormones and body.
There's nothing to be scared about, and we really,
Absolutely.
Exactly, and we encourage people to see a specialist sooner rather than later, for sure.
Absolutely, absolutely, yeah.
Okay, number 6. I've heard that all specialists want to go straight to IVF. Is that true, or do doctors try other routes first if their diagnosis warrants it?
Okay, so there are specialists and then there are fertility specialists. So fertility specialists are trained in the best way, the most effective way, the most cost-effective way of getting a patient to conceive. And IVF is not always the most cost-effective way of doing that, all right? The most cost-effective way would be to get the baby or to make the baby at home. So we will do tests, and based on the investigations that we have done and the scientific evidence that's available, we will then make a recommendation as to what is the best way for the patient to conceive. Many a times it's just about the timing of intercourse, something called timed intercourse. Sometimes you might have to do intrauterine insemination, but if the tubes are completely blocked or the sperm parameters are significantly abnormal, we may decide to do IVF or ICSI. So no, IVF is certainly not the first-line treatment for infertility. If you get offered that as a first line, and you should get reasons why they do that. It's not the first thing that should be done.
Thank you, Dr. Biko. Okay, number 7. Is IVF a guaranteed way to have twins?
Well, very interesting question. First of all, we, as fertility specialists, we agree that having twins is actually not the best outcome of IVF or any fertility treatment. the best outcome for our treatment is to have one baby. We say it's one baby at a time. All right. So whatever we do, whether it's doing IVF or ICSI, firstly, there is no guarantee that you will fall pregnant. Okay, we can do the best we want to do. Everything can be 100% well, but the implantation rate in human beings is so low that even with normal embryos and a normal uterus, the best rates we can achieve is about 40%. So we cannot guarantee you a pregnancy. Worst of all, we can't guarantee you a twin pregnancy. And ideally, we do not recommend twin pregnancies as a routine because the outcomes of a twin pregnancy can be quite hectic on the babies and on the pregnancy itself and on the mother. So the best outcome is a singleton baby, one baby at a time.
Perfect, thank you. So how many cycles of IVF do you recommend a couple should budget for when they're starting out? For example, I've heard that you need to plan for at least 3 cycles per baby you are trying to conceive.
That's a fair question. It's not only about the number of cycles that's important, because one patient in one cycle can give me 20 eggs, and another one can give me 1 egg per cycle. So if I want to say 3 cycles, I mean that the girl who's giving me 20 eggs must do it 3 times, 3 cycles. The one who's giving me 1 egg is going to do 3 cycles. It's not going to be the same. So the important thing is how many eggs, how many good quality eggs do we have? So ideally, one needs at least 15 good quality eggs to have a decent chance of having 1 baby. So if it takes us 5 cycles to get 15 good quality eggs, then that is what we should budget for. If it takes me 1 cycle to get that, I have a very good chance of getting a baby on my first cycle. And the number of eggs that we produce generally is dictated to by the age of the patient, all right? And the presence of other diseases, like if somebody's got PCOS, they tend to produce much more eggs than those patients who don't have PCOS and those with a poor ovarian response. So it is the number of good quality oocytes. In general, I would recommend that one should budget for between 3 and 6 cycles to ensure that one will have one child. In the UK, the NHI, they normally pay for 3 cycles, and the move now is that they should probably consider to move to 6 cycles to ensure the presence of 1 child. So it's a matter of eggs, not so much a matter of cycles.
Okay, great. So you'd be able to advise them more after the first cycle. So from there you can give, yeah. Okay, perfect.
Excellent, that's correct, yeah.
Excellent. So number 9, what can be the reasons as to why the embryo doesn't implant? Say the embryo is a good quality embryo and then it doesn't implant. What could be the reasons?
Just like our children, some embryos don't listen to us. They they do their own things. You think you've raised a good child and then they do something else. Same thing with embryos. So essentially, there are 2 big factors why implantation doesn't work all the time. In fact, naturally, the majority of eggs, good quality eggs, will not implant. Naturally, up to 60% of good quality eggs will not implant, and we don't know what's the reason for that, okay? But a couple of reasons have been identified. The quality of the embryo and problems with the uterus are the main reasons why implantation fails. Now, what affects the quality of the embryo is things like maternal issues and paternal issues. Now, if the father's got, even the sperms look normal, but they are abnormal, there's high levels of DNA fragmentation, for instance, that can affect implantation, the quality of the embryo, and eventually implantation rate. And then the mothers, on the other hand, the age of the mother is very important, because the older the woman is, the higher risk, there's a risk of abnormal eggs being formed, right? The presence of hormonal problems can be problematic, immune problems, the metabolic conditions of the mother can also affect the implantation. And then coming to the uterus itself, abnormalities in the uterus such as fibroids and scars, especially scars in the uterus, can impair implantation. Now we see a lot of ladies who come to us and say, "Doc, I want to come and clean my womb." They want to do DNCs and stuff like that, because some of the doctors do it on a yearly basis. Now that's the worst thing you can do to yourself, by doing a DNC to clean your womb, because the womb is never dirty. It cleanses itself with every cycle. There's no place for doing routine womb scrubbing for the purpose of cleaning your womb. And then there's a big aspect, which is the genetic aspect. There's a lot of genetic factors which can impair implantation of the embryo. So implantation is a big thing, and it's not well understood, but there's a lot of factors that can impact implantation. But importantly, under normal circumstances, the majority of good quality embryos will not implant in a good-looking uterus.
Sure, I love that about them not listening. Brilliant. Okay, so what is the age limit, Dr. Biko, for IVF?
Okay, so we're going to have to go to America for this, because we use mostly their guidelines in terms of this aspect. So to do IVF using your own eggs, as we said earlier on, the quality and the quantity of the eggs decline as we get older, to the extent that by the time patients reach 43 years, around 43 years, the quality of the eggs is so poor that the pregnancy rate is probably less than 5% if we use your own eggs. So from about the age of 43, 44 years onwards, we recommend that in the majority of patients that they must consider to use donor eggs. All right, so you can conceive with donor eggs from the time that you can't use your eggs until about the age of 55, 56 years. All right, so if a patient has got no chronic or no serious chronic medical conditions, we can use IVF, offer them IVF up to the age of about 55 years. All right, but those with medical conditions, one would probably go up to the age of 50 and then not offer it after the age of 50, because we are worried about the impact of pregnancy on the health condition of the patient. We're also worried about the impact of pregnancy on the outcome of the baby, because if you're 50, we know that if you fall pregnant, the risk of diabetes goes up, the risk of hypertension goes up, and as we get older, in any case, those risks go up in general. So now you're going to have two risks of doing those problems, and then pregnancy itself increases this risk even more. So we have to make sure that those patients who conceive at an advanced age, they're medically fit to do so. Also have to inform them that the risk of delivering by cesarean section tends to be higher in patients of an advanced age. So 55 is probably the maximum age that we'll consider in most patients.
Okay, thank you. All right, so is egg freezing or embryo freezing preferable when the woman is single and worried about her age? Example, do eggs or embryos freeze better?
I think preserving your fertility is always a good thing to do, all right? Especially if you're not in a stable relationship, or let's say you're studying, you don't have time to now, and you know that, because you know that as you get older, the quality and the quantity of eggs are going to decline. So it is a good idea, if you can afford it, to preserve your genetic material. Now the next question is, should you freeze eggs or should you freeze embryos? In general, it is better to freeze your eggs because it's your eggs. If you freeze embryos, then there's somebody else involved. It's your eggs and somebody else's sperms which come together. Should you guys break up in the future, then we've got a problem with this embryos. Then you don't have much say on these embryos, because now the partner that you broke up with has a say in these embryos. So generally in our setup, we would recommend that patients rather freeze their eggs instead of freezing their embryos. As to which one is better between egg freezing and embryo freezing, it should be the same. There should be no difference. But some of the clinics, we know that some clinics don't have experience in freezing eggs, would rather freeze embryos. So you need to inquire from the clinic that you're going to, how good are they in terms of freezing eggs as compared to freezing embryos. But in my opinion, it is generally better from a legal point of view as well, future legal point of view as well, to freeze your own stuff alone. If your partner wants to do that, he can also freeze his sperms, but don't make the embryos now, because life happens, huh? And if it happens, you might be in trouble. The guy drops you at 40 years of age, now you've got no eggs sitting with embryos which you can't use. Be careful.
Yeah, sure. That's a very interesting thing to have to think about. There's a lot of the implications, hey? You're all happy now and you want to have kids in the future, and then sure, now you're fighting about embryos.
Absolutely. Can be a big problem.
That's very good advice, Dr. Biko. Thank you. Okay, so number 12, in patients with high DNA fragmentation, would you say ICSI cycles that use the PICSI technique have a considerably higher chance to achieve pregnancy rather than those who had sperm selected only by morphology assessment?
It's a very technical question. All right, now there's quite a lot of evidence about the place of PICSI, or what's also referred to as physiological ICSI compared to normal ICSI in patients with high levels of DNA fragmentation. Look, the best way to manage these patients is to manage the DNA fragmentation, or to prevent it, because we know mostly what is the cause of fragmentation. Because currently the evidence, there's a lot of evidence that has shown that PICSI does not improve the pregnancy rate, the live birth rate, as to compare to normal morphology. And there are some studies which show that it may increase it. So in general, at the moment, we do not believe that PICSI should be used as a gold standard for managing men with high DNA fragmentation. So studies are not very, it's not quite clarified yet, but the general consensus is that no, PICSI does not increase the pregnancy rate in men with high DNA fragmentation. So rather, let's prevent it. Let's treat the ROS, reactive oxygen species, by giving the patients appropriate treatment. Let's manage the other thing which causes high fragmentation is because the time interval when patients have to come and give sperms. The longer you wait, the more damage we get to the sperm. So you have to reduce the time. Instead of waiting for 3 days before you give us sperms, you can wait for an hour, 2 hours to get fresh sperms. Fresh sperms got less DNA fragmentation than those sperms which have been there for a long time. So let's manage that aspect and not think about PICSI or IMSI or the other stuff. So the evidence is not very supportive now of using PICSI to manage DNA fragmentation in sperms.
Thank you. Okay, our final question, Dr. Biko. Can oocytes repair fragmented DNA of spermatozoa? That's eggs and sperm, right? Oocytes, the eggs.
Yeah. So what happens is that immature sperms have the ability to fix some of the problems in themselves. But once the sperms themselves are matured, they cannot fix anymore. They stick with that problem. All right. Now the oocytes then have got a role to do to come and help, because the oocytes in the early embryo can fix many of those problems, those fragmentations. So there's self-correction or self-fixing of that. They can do it, but the success of that depends on the amount of fragmentation. Like with everything else, if there's excessive fragmentation, then the ability of the eggs, the ability of the early embryo to do that will fail. And if it fails, the embryo might grow well for the first 2 days. And then from the 3rd day, when the sperms kick in, genetic of the sperms kick in the embryo, then we get progressive loss of growth, and basically you get failure of the embryo to develop. So to an extent, yes, oocytes can fix problems in the sperms, the DNA fragmentation problems in the sperm. They can kick them out and fix them.
Sure, that is very interesting. That was a very interesting conversation, Dr. Biko. I learned a lot as well, and I thought,
really?
you know, I don't know everything. But
I thought it was obvious.
So no, thank you very much for all of that information. That was great, and thank you also to Femicare for your support of IFASA and for supporting all our initiatives like this and being available to help us when we request it. You guys are always very helpful whenever we ask you some random things, whether you'd be up for it, you're always so. I do appreciate it. And I also want to implore the public to follow your Facebook page and your Instagram account too, as there are always a variety of interesting articles and videos posted on them. So they can also learn from them on your social media accounts. So I want to ask them to do that too.
No, it's an absolute pleasure to be involved with IFASA, because IFASA, like I said earlier, they're doing an amazing job. And I know the work you're doing. I'm involved with some of the stuff that you guys are involving in, because your objective is the objective of getting the patients to qualify where they should get their rightful position in society, and to avoid all the problems that they are going under now with the medical aids, with the discrimination that they undergo. And I know IFASA is doing a great job, and we are grateful to be part of the IFASA journey in managing these aspects of our patients' health. Thank you very much.
Thank you, Dr. Biko. I appreciate it. Bye.
Bye.